So we'll hit the record button. But good morning. We appreciate you all being here for the benefits of youth mental health screening this morning. We were thrilled with the amount of people who had registered and were interested in this topic. We find definitely at this moment, especially throughout the pandemic, it was just a very pressing topic that we thought that we could bring to this new year and to really talk about a little bit more in depth. And then also at the end, we'll kind of talk about opportunities for those who work in schools in Morris County who would be able to utilize different screening tools, who are interested in different screening tools. So to start off, my name is Ashley Brown. Also along with me today is Kelsey O'Connor. We both are the Screening Brief Intervention Referral to Treatment Project Coordinators. So this is our realm. We'll talk a little bit more about what we do there at Prevention is Key. This is a project that is through Prevention is Key. So those who are new on the call, who don't know anything about Prevention is Key. We're located in Rockaway, and we just have, a wide range of different resources that we offer to our communities here and in Morris County and surrounding counties. Really, our mission is to promote, healthy lifestyle for every person, really by helping others, changing lives, and making differences through education like this, advocacy, passion, and really support systems. So in short, we do provide Intoxicated Drivers Resource Center. We have an ever-growing recovery center called CARES, which stands for Center for Addiction Recovery, Education, and Success, that offers many different recovery services. And then for individuals in active recovery or those seeking recovery. And then lastly, why we're here today. We have our prevention team and our prevention programs that we provide really throughout our county with different, we do a lot of school-based prevention programs, community trainings programs, and community coalitions that focus on different areas of topics. So before I introduce our trainer for today that we are thrilled to have back again, back by popular demand, I will say, Heather has been a true advocate for Prevention is Key and is always willing to come back to Morris County and present to all of you. But just a little housekeeping. This is not the webinar feature, so we felt that it's an opportunity if people want to, interact a little bit more. We felt that's a better option as hosting it as a meeting. But feel free to throw in the chat box. We'll kind of make sure that we're looking at it. Put your questions there for Heather, and then also if we want to at the end, we did leave some time at the end to answer questions as well. So if you want to keep your questions to yourself and ask at the end, we are more than happy to do that. So whatever you feel comfortable doing. Again, this webinar is being recorded and we will send it out along with the PowerPoint. So again, I want to kick it off. I want to thank you all for being here and welcome our presenter today, Heather Ogden. Again, we're so thankful for her for bringing her expertise to Morris County, as she's really been an integral part in our SBIRT project that Prevention is Key has to offer. And again, we'll hear a little bit more about that after. So without further ado, Heather, I'm going to hand it over to you.
Thank you very much, Ashley. Good morning, everybody. Thank you for joining us today. My name is Heather Ogden. My day job is the Advocacy Coordinator and Training at the National Center for Advocacy and Recovery in Behavioral Health, NCAR-BH for short. I myself am a person in long-term recovery. I've been working in the field for over a decade. I've done I've worn a lot of hats during my time in the field. I've worked as a counselor. I've worked as a peer in both mental health and addiction, but during my entire tenure, I have been a voracious advocate for recovery in both mental health and addiction services. And I stumbled as an advocate. I stumbled across SBIRT many years ago and thought, why aren't we doing this everywhere? It's something that is like this really, it's like the best kept secret, and I don't want it to be a secret. So I got certified as an SBIRT trainer. And I've been certified for many years, but finally we are at the point in New Jersey where we are starting to implement it. And I'm really excited and grateful to pick that they brought me on as the SBIRT trainer and are giving me the opportunity today to talk to you guys a little bit more about early intervention and screening. So I work mostly in the recovery end of things, but we have learned over the past few years that there should be no division between prevention, treatment, and recovery. It's all one big spectrum. So with that, I'm going to go ahead and share my screen and give you an overview as to why we're all here today, and hopefully teach you a little bit more about why we're talking about screening today. So I do want to say thank you to people that are introducing themselves in the chat. As a trainer, I like to know what you guys are currently doing, what brought you here today, what your interest is. This helps me to kind of target what I'm going to say to you today beyond what's obviously on the slide in front of you. So with that, I'm going to jump right in. As Ashley said, if there are any questions, please pop them in the chat. The PIC team will be monitoring it because it's hard for me to do both at the same time. But if there's something pressing, go ahead, PIC team, and interrupt me and let me know that somebody has a question. All right, so here's what we're gonna go over. I warn you, it's probably a ton of information in a really short amount of time, but the slides will be sent out and the recording will be available. And I put all the references. I didn't come up with any of this myself. So I left them just in link form so you can easily access any place that I've gotten the information from. So what we're going to talk about today, we're going to talk about how we are now in a behavioral health crisis, which is also a public health epidemic. We're going to talk about different types of screenings, and then we're going to talk about SBIRT. So to start with, did you know? Now, looking at my audience, I know that you do know some of these things, but 50% of all mental illnesses present by age 14. So that adolescent time period is when a lot of things start to become a little bit more obvious. We don't know necessarily that they're mental health issues yet. Unfortunately, we miss a lot of them because at age 14, you know, our kids are going through lots of changes. Sometimes we discount it to normal adolescent behavior as they enter the teenage years. 75% of all mental illnesses start to present before the brain is fully developed. So everybody's brain develops at a slightly different rate, but it usually stops developing by approximately age 25. It's usually a little bit later for males than it is for females. Their brain tends to be fully developed a little bit earlier in the 20s. You can't pinpoint an exact year, but these are two age ranges, you know, those adolescent years going into teenage years and then going into young adulthood, that a lot of mental illnesses present, and we tend to miss them because they're also huge transition times for people of that age. The age of a person's first use of substances can impact the future of developing a severe substance use disorder. So basically, the earlier the use, the higher their chances of developing a severe substance use disorder later on in life. So when people that are in drug and alcohol treatment are surveyed, we found that, so these are people that have moderate to severe substance use disorder, so they are already in treatment for it. Their average age of first use is around 14. That's for alcohol. And then for other substances, it's around 16. It's not on this slide, but the ages for people that do not develop a severe substance use disorder, their average age of first use is closer to 17 and then 19. So there is a correlation between earlier use and later problems. Since the pandemic, we have seen a rise in pretty much everything. Suicide attempts, eating disorders, anxiety, depression, overdoses, problematic substance use. This has happened in all age demographics. We have seen a rise in all of these things in every age group, but the highest spike that we have seen so far is in adolescents, especially high school age adolescents. Only 10% of people that need treatment for substance use disorder actually get that treatment. So that's a lot of people that need assistance that are not getting it. Only 1/3 of adolescents with mental health issues receive the professional help that they need. So we have a lot of people. Now, keep in mind that these numbers are pre-pandemic, and they're also a couple years backtracked because we all know there's a lag in statistics. So the latest years we have for some of these statistics is 2020, but most of them are from 2016 and 2017 because those are the last years that they compiled the data. So obviously, with the pandemic, we are going to find that these numbers have changed. I'm sure you have all already seen the effects in front of you, our school folks, especially like our counselors and our nurses. I know that you have a lot more kids coming to you or being sent to you. So we're already seeing the fallout, and we're not even at the end yet. So we all knew that the addiction epidemic was in full swing well before COVID ever hit the United States. But what we have seen is that this epidemic that was already happening, and I purposely shy away from using the term opioid epidemic because it's not just about opioids. This is about all substances that people use to get out of themselves and develop a problematic relationship with. So this includes alcohol. This epidemic was already happening well before COVID hit. And now we are seeing a mental health crisis that is almost paralleling our addiction crisis. Obviously, we do not have statistics based on, a worldwide pandemic, because this is the first time we've seen it in our lifetimes. But we do have statistics on previous catastrophes. So like 9/11 and Hurricane Katrina, we have lots of research that was done after, but during and after these events. And the average is that about 6 months after the catastrophe, that's when we see a large spike in demand for services. So that's when we see a spike for especially mental health, for depression, anxiety, suicidal ideations. We see the alcohol requests. So people that develop an alcohol use disorder or a problematic relationship with alcohol, that actually doesn't happen for a couple of years after the catastrophic event. So there's a huge lag time in between the end of the event and the demand for services. And obviously, we're not quite at the end of our COVID realm. It just seems to keep going. So we're already seeing the spike, but historically, the spike isn't going to happen until 6 months after this is over. Now, granted, this is kind of like weather forecasting. Like, we don't know exactly what will happen. We can only base it on what we have seen in the past. Based on what we've seen in the past, we should really buckle up. We're going to have a huge problem on our hands, which is why we are talking about it a lot now, because we really need to get some things in place before that happens. It's such a concern that the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association have all actually agreed on it, and they have declared a national emergency in children's mental health. To back that up, the Surgeon General also just issued in December a public health advisory on the same topic, specific to youth. Everybody sees it coming and they're trying to get things in place. So again, thank you to everybody that showed up today, because you all see it coming too. And I know that you're here wondering what you can do to assist in this. So a lot of this training is based, I wanted to go directly to the experts. The Surgeon General had just put out this advisory, has been studying this a lot. He's actually the same person. We had a Surgeon General under President Obama who put out the very first advisory on addiction. So he's pretty plugged into our realm, to behavioral health. And he says that whenever you have large numbers of people who are dying for preventable reasons, it constitutes a public health issue. So he's very big on making sure that people know
Yes,
that
hello, mi amor.
behavioral
Adela
health
Gonzalez. I am calling because
is
I would like to
public health.
see if you see children. My daughter is
If
5.
everyone could just make sure they're muted themselves. I'm sorry, Heather.
Thank you, Ashley. No, that's cool.
Okay, thank you.
So what he's trying to get across, and one thing that I'm sure most of you know, but this is something that we need to kind of get everybody to know, behavioral health is public health. We have this tendency to separate behavioral health from physical health. And this is not working well. We need to realize that they're brain disorders. The brain is part of the body. Therefore, this can be considered a physical health issue. Brain disorders cannot be separated. If something is affecting your brain, it's going to affect your body. And if it's affecting your body, it's going to affect your brain. An example is anytime that that you're in physical pain for something, whether it's as minor as you stubbed your toe or as severe as you've broken a limb, we're usually not in the best of moods when that happens. They are linked. We should stop making a distinction between the two. We need to do that in order to get this accepted in the general public as a public health crisis. So another thing that we do when we keep them separated is we perpetuate stigma. And this is one of the biggest things that that continues to drive deaths of despair. Not only does it make it harder for people to accept their own diagnosis, but it makes it much more difficult for them to ask for help or to seek or get treatment. So we need to create a dialogue to take this kind of out of the shadows. It doesn't help that our insurance setup in the United States also treats these disorders as completely separate from each other. Most people know from their own health benefits that you've got one coverage for physical health and one coverage for mental health. And usually for mental health, you have to call the number on the back of your card and try and find a person that accepts your insurance. And you have to go through all of these hoops to get mental health assistance that you do not have to do for physical health. And here's something that's, a lot of people don't know. They're not allowed to do that. There's actually been a law on the books since 2008. It's the federal parity law. And it says that insurance companies have to cover behavioral health the same way they cover physical health. We all know that that's not happening in practice. The only way that we get them to do it is if we make enough noise and we demand it. So part of the thing with having federal laws on the books without any kind of oversight or people to enforce it is that states have to come up with their own version to enforce that law. New Jersey actually does have a parity law. It was passed in 2019, I'm sorry. But it's one of those things that was supposed to kick in a year later. That would have taken us to March 2020. We all know what happened in March 2020. So the last thing on people's minds was making sure that this part of it was enforced. However, we know now that we really need to start demanding this of our legislators and of our insurance companies, because there's a lot of people that are going to need their mental health benefits, and we need to make sure that they're covered. The whole point in talking about early screenings is to start earlier conversations and ongoing dialogues. By talking about this early, we are normalizing it. I'm a person in recovery from both substance use disorder and mental health issues. And part of the reason it took me a while to find those places in my life was because I was ashamed to talk about it. because we didn't talk about it. At my age, like, this is not a dialogue we had when I was younger. When we talk about it earlier, then our young folks are not ashamed of asking for the help that they might need, or letting somebody know they need some extra assistance or they're not doing quite as well. So screening starts the dialogue. That's what we're hoping to do. By taking these issues, out of the closet, out of the dark, then we can make a huge impact. So here's our Surgeon General again. He says it would be a tragedy if we beat back one public health crisis, meaning COVID, to allow another to grow in its place. Mental health challenges in children, adolescents, and young adults are real. They are widespread, but most importantly, they are treatable and often preventable. So what can we do? How can we see this? We know it's coming. It's starting now. We see it coming every day. These are the guidelines from the Surgeon General's report. So we went over this already. We have to recognize that mental health is an essential piece of overall health. Like, mental health is health. We need one to have the other. We want to empower youth and their families to recognize, manage, and learn from their emotions. So, we all have people that still believe, like, they're still kind of perpetuating that idea of boys don't show their emotions, girls are too emotional, all of these historic things that, were once considered societal norms, we know today are dangerous to reinforce as norms. So we want to encourage people to talk about that and open their minds to looking at emotion a different way. We want to ensure that everyone has access to care. We want to support the mental health of children and youth in educational, community, and childcare settings. So that's mostly what I'm assuming most of our audience is here to do today, is to support mental health in the children and the youth that you work with. We also need to address barriers, because we all know that all of these there are barriers that leave certain groups in more danger of developing more problems. We want to take a look at that and make sure that we're leveling out that field. And of course, this is from federal government, so they want the data. They want the data in as close to real time as possible. Maybe someday that'll happen, but it is important to keep statistics on this, because this is what convinces people of what works. So how do we do this? We do it with screening. Excuse me. So universal screenings for behavioral health conditions, they improve health, they improve wellness, and they improve treatment outcomes for people that later need treatment. So screenings. Right now, everything is under the umbrella of screenings, because obviously there's lots of different ones for lots of different conditions. But in general, talking about screenings, we already do this for everything else. So most of us have a standard well appointment with our doctor. We get a physical. We do this for our kids. We go to the dentist. We go to the eye doctor. We have hearing screens. We have our kids go through scoliosis screenings. I have 3 kids, but I have my youngest is a middle schooler, and I just got, the notification that they're doing scoliosis screenings. I get this every year. Every year they're doing the screening. Why do they do that? Because they know that if they catch the problem early, that the children will have a better outcome and hopefully avoid severe illness. So by catching problems early, we can treat them earlier, and that means that they have a better prognosis. So for instance, unfortunately, we all have loved ones, or some of us ourselves have had cancer. We know that if we catch cancer in its earlier stages. It's much more receptive to treatment. That same idea applies to all of these other screenings that we go through, that our doctors do for us, that we sign up for. It's why we have blood work every time we go to the doctor. Now that I am of a certain age, I have all of these other screenings that I have to go for. You know, you add mammograms and colonoscopies, and these are all things that we accept as standard practice. You hit a certain age, these are things that you get screened for routinely. Pardon my dancing lights in the background. I have a cat that's playing with them. Little disco action for you. So we want early intervention. We want earlier treatment. It leads to better outcomes. It also costs a fraction of what it would cost to treat these when they're much more progressed. So obviously, treating cancer at stage 1 is easier than treating it at stage 4. You have to be much more aggressive. We also know that later diagnosis leads to much poorer outcomes. Catching things earlier, you have a better outcome. It costs a lot more, and unfortunately, sometimes we catch things so late that it's too late. We can't treat it, it's progressed too far. The same principles apply to behavioral health. If we treat behavioral health the same way we treat physical health, all of the things that I just said still apply. If we catch a mental health condition or a substance use disorder early, the chances of that person getting well are much higher and will cost a lot less. Here are some standard behavioral health screenings, which I'm sure some of you use already. So these are screenings that are evidence-based and have already been proven to be effective. There's data out there that backs them up. One is for depression, one is for anxiety, one is for PTSD, and then there's a whole bunch for substance use. So the PHQ-9, now I know a lot of us, self included, when I was working as a counselor, I used these short terms, the PHQ-9, for years and had no idea what any of them meant. So if anybody else out there is like me, I actually put what these initials stand for. So it actually stands for Patient Health Questionnaire, which is interesting. It must have been originally developed for doctors, and I do know that doctors use it. I myself have taken this screening at my doctor's office. They do it for my kids every time I take them for a wellness visit. It is a universal depression screening, and it can be used for most ages. I can't say all because technically it's only certified for ages like 3 to 80. I don't, I guess because like 1 and 2-year-olds can't answer the question. I don't know why 80 plus, it's not approved for that, but I'm trying to be as accurate as possible here. So most ages, you can use this. The GAD-7 is, again, most ages, used for generalized anxiety disorder. There is actually a PTSD screening. I was not familiar with this one. And it's because it's still used primarily in primary care doctor settings. That's what it was developed for. That's where it's used mostly. And keep in mind that all of these questionnaires are not to diagnose, even as a doctor necessarily, they're not to diagnose or treat, they're to flag people that could benefit from a higher level of care. So if you're taking these screenings at your primary care doctor's office and you, are shown to be at an elevated risk for depression, anxiety, or PTSD, many times your primary care doctor will say, okay, I would like you to go see a specialist. Again, not unusual if we look at this through a physical health lens. Your primary care doctor might find a problem. He's going to send you to a specialist to address it. Same thing with your heart, your kidneys, skin conditions. There are all these specialists out there that they're going to send you to treat the problem. Same thing with behavioral health screening. So if you are shown to be having symptoms of any of these things, they will refer you to somebody that can help you at a higher level. For substance use screenings, again, these are all evidence-based and have been around for a while. There's a lot of them. So it really depends on the setting and who's doing the screening. For alcohol, most clinicians use the audit, and most doctors, like primary care doctors, will use the cage method. For other drugs, other substances, there's a whole bunch here. The one that most people are familiar with is the DAST. There's actually 2 of them. There's one for adults and one for adolescents. And then the one that we talk about the most in our SBIRT trainings is the craft screener, because that's the one that's approved for adolescents. So you want to make sure that you have the proper screening tool for the proper audience. So we keep talking about SBIRT, SBIRT. What is SBIRT? Well, it's an acronym, of course, because we really like acronyms in this field. Like everything has to have an acronym. When I first came in, we called it alphabet soup. There's actually like a 70-page guideline to New Jersey behavioral health acronyms that we found back in the day. I don't know if it still exists. It would need to be updated. I bet it's much longer now. But SBIRT stands for screening, brief intervention, and referral to treatment. So it's a 3-prong approach. It can be used for anybody, right? So think of SBIRT as a philosophy and an overall method. It's not the actual screening tool, okay? The tool that we use in SBIRT depends on our audience. So these screeners that I just went through, the audit, the cage, the tips, taps, DAST, craft, those are the actual screening tools that are used. SBIRT is the method that we use the screening tools in. The idea behind it is to find the issues before they become gigantic issues. So for years in substance use, we have had this idea that people have to hit bottom before they get help. That is wrong, and it's fatal. People can, if they're offered assistance and support earlier, will often get well earlier, okay? So the idea behind SBIRT is to find the problems when they're smaller problems. You know, we want to find it at stage 1, not at stage 4. It's very simple, this 3-pronged approach. So you have your screener. I'm going to say we're using the craft one because I think most of you work with adolescents. You use the screener. If the answers are no, you're done. That's it. They're not positive. You don't need to go on, and you don't have to do the other 2 pieces, okay? Most people will fall in that first round because most people don't have an unhealthy relationship with substances. If a person falls at the opposite end, where they're already in what will probably be diagnosed by somebody else, not us, as a severe substance use disorder, if somebody has a problem already, they'll fall in that RT part, that referral to treatment piece. That's usually only about 5% of the people that are screened. So I know a lot of times people, when they hear about SBIRT, they're very concerned about this referral to treatment piece. But New Jersey has come a very long way in putting people in place that know how to navigate the system. So not only are there lots of people to help in the referral to treatment piece, it's really not that common. It's usually only about 5% of people that need that referral to treatment piece. The thing that makes SBIRT different is this BI, this brief intervention. It's, you know, as far as the field is concerned, it's innovative. It's the most useful piece, though. So what this section does is, so SBIRT gives an opportunity to professionals and the people that they're working with, their clients, their students, their patients. You can have an honest conversation that's not judgmental with a person about their relationship with substances. Okay, we're not talking about them having a problem. We're not talking about them being diagnosed. We're just talking about what their relationship with these substances are. And we're trying to build enough of a rapport that we can continue this dialogue. Okay, so the brief intervention piece can be as short as one session. It can be as long as many as you are allowed to within your time frame. But this is for all of the people in between. Okay, so we all have, the students that don't drink at all. We have the students that drink too much, but we have a whole lot of students that fall right in the middle that aren't yet drinking problematically, but if they do drink, they're drinking too much. Why are they drinking? This BI piece of the brief intervention in SBIRT is what starts a dialogue about that for this whole big subset of people that are being screened. Why does it work? Well, it's short. If you're just doing the screening piece and they come up negative for it, which is most people, it's less than 5 minutes. It's used universally. So they've done SBIRT approach in a couple of different ways. They were doing a targeted approach. And that's not something that is recommended. It is recommended that it be either universal or randomly universal. So you shouldn't just screen people that you think already have a problem. This is something that should be used for everybody. It also helps normalize it. So like everybody gets blood work done when they go to their doctor. Everybody gets a scoliosis test every year in middle school. If you're getting this screening every year, it normalizes it. It just makes it more acceptable to everybody. You can target one or more specific behaviors. So the thing about using the craft screener for adolescents is that it can also create a dialogue about what's happening around them with substances, because there's a question in there that could flag that this child doesn't have a problem, but somebody around them does. And again, you're creating that rapport and that dialogue where you can hopefully get some assistance to the person before things are at a catastrophic level. This also works better because it's happening in a normal setting. So it's not happening in, substance use treatment. There seems to be a lot of things happening lately where people are, or younger people especially, are being sent to treatment when they're not actually at a point where they should be going to treatment yet. They're being sent for a severe substance use disorder when they don't actually have a severe substance use disorder. That is very detrimental to a younger person, especially. Having this happen in a normal setting, school, nurse's office, wherever it's happening, makes it much less threatening. It's pretty comprehensive, and it's got a lot of research behind it. It supports this model, and it's an easily adapted model for lots of different people in lots of different places. These are some of the places that it has been used. It's been used in emergency departments. It has been utilized in primary care settings. I remember the first time I ran into an SBIRT screening at a doctor's office. I was so excited. I ran up to the desk. I was like, "Can I have a copy of this questionnaire, please?" They thought I was nuts, but then I told them what I did, and they were like, "Oh, okay, great." Employee assistance programs, they often use this to help you find an appropriate source of help. Because again, just because people are having problems with substances does not necessarily mean that they have a substance use disorder. I think everybody's got some experience with themselves or with somebody else. There could have been a time in your life that was rough. Maybe you were drinking a little bit more than you normally did. You got through the rough patch and then your drinking went back to normal. There's a lot of people that fall into that category. But it's better to have support during those rough patches. And obviously, a place that we want to see SBIRT used universally is in schools. It does not need to be performed by a licensed professional. Now, I know that In most school settings, they're going to either utilize a nurse or a counselor for SBIRT. That will really it comes down to the decision that the higher ups of the administration made. But as an SBIRT trainer, I can tell you that, you know, I'm a fan of teaching lots of people how to use SBIRT, especially in an adolescent population. I think that, you know, coaches and music teachers and, you know, I was a theater kid. So like the people that work in the theater department, they're really good people to have in this mix as well, because a lot of times the rapport already exists with the kids because they're spending a lot of time together, and they'll be more inclined to talk to those people about what's actually going on. You know, for the standardized screenings, you know, they're going to want somebody who is doing the proper notation and keeping the data and all that. But looking at this from, you know, an advocate and public health and wellness perspective, I think this is a great way for people to learn how to have difficult conversations, especially with, you know, a population that is notoriously difficult to talk to. I have a house full of teenagers, so I get it. You only need to be trained in how to administer the screening the right way. So it's already been used successfully in several states. It's actually a law that everybody gets screened in Massachusetts and Washington State. So they've got lots of statistics that are showing how effective it is. Student reaction has been overwhelmingly positive, which was surprising to me and is surprising to a lot of people. But the students actually really like being able to have this open dialogue about things that they felt they couldn't talk about. So here in New Jersey, we've introduced SBIRT initiatives in Morris and Passaic counties, and all of our folks there are collecting data. So it's great that at some point we're going to have New Jersey specific data as to the effectiveness of SBIRT. And all of the statistics from wherever you pull them from, it shows that it helps identify students with risk factors that nobody knew about. So opening this dialogue really helps catch kids much earlier than we are currently catching them. And that's what early screenings are about, is to catch the problem before it becomes a crisis. The brief intervention piece where you're creating this dialogue, the students are saying that it's really increasing their connection with adults at school. And I think especially in the after COVID era, this is something that we really want to make sure is happening with our kids, because I know that there's a lot of them that feel kind of distanced, especially if they had to switch a school during the remote era. So like if they went from elementary to middle or middle to high school, they missed out on that piece in the middle. So there's tons of references that give you full-on statistics, but this is the one that really jumped out to show why SBIRT is working. So at a 6-month follow-up after using SBIRT screening, illicit drug use was 68% lower, and heavy alcohol consumption was 39% lower. So this was in, I can't remember, it was several hundred students. You know, these statistics are only done within the programs that they're being held in. So I don't have like this large, massive national database, but that's the whole point in these trainings, is that that's what we want to get to show everybody that SBIRT is working really well. All of the statistics are coming out of these states saying that it's helping. It's helping kids lower their use. It's helping kids connect with adults, and it's getting kids support and assistance faster and earlier than it ever would have happened before. So here is where I got all of this from. I'd love to take credit for it, but I'm not that smart. But I am a research geek. So these should work as links if you want to do follow-up on it. Please feel free to. And with that, I will turn it back over to Ashley so she can take it from here.
Great. Thank you so much, Heather. I'll just have a couple things to say. I'll make it brief, and then we'll get to questions if anyone has any. So thank you, Heather. That was great. I feel like every time you present, I learn something new for sure. So I'm gonna just go ahead and share my screen real quick. Oh, I don't want to do that. Oh no.
While Ashley's doing that, I did put my email address in the chat. If questions occur to you later, or you have any questions about trainings, I do all kinds of different trainings, not just SBIRT stuff. And if you're interested in learning more about our advocacy program, please email me, and I'd be more than happy to talk.
Can everyone see my screen? It says SBIRT up there, or is it my home screen? No. This is always when I have two screens, I mess it up somehow. Oh, here we go. That's why. Okay, now can everyone see it? Okay, cool.
Yeah,
All right, so just to kind of piggyback off of what Heather was saying, just an opportunity for those who are on the call who may come from a school. We do at Prevention is Key offer a project that that we've been working on for the past couple years, and it's offering SBIRT, so screening, brief intervention, referral to treatment, to those middle school and high schools who are interested in implementing that. Prevention is Key is here for technical assistance. As Heather said, Heather has been our trainer for the past 2 or 3 years in getting all those school personnel trained. And so this is just really an opportunity to get those screening tools in your school. So some of the perks is really, again, you have technical assistance, you have Kelsey and I for any type of Q&A and questions. We set you up with the training, we set you up with the data collection. And again, we're just ongoing support for you. Heather is, again, she provides those trainings. We have recordings of trainings. We typically offer them in the beginning of the school year, but we do have recordings. So you can become an SBIRT school at any time during the school year. And really, again, it's just like the whole goal is to really increase the capacity of the student services to really effectively and efficiently address, alcohol and substance use and mental health. And then overall, that really provides and promotes school engagement and really has been shown to increase, learning outcomes. So, and then lastly, another perk is for each school that does participate, of course, you do have to meet a number of students that you do screen. This is just an opportunity, this project, it's a pilot project that, again, we're just here to advocate for SBIRT throughout the whole state, or screening in general throughout the whole state. So it's an opportunity to be a part of that. And then also have those conversations with those students. Just with all the data and the research that Heather presented, we could definitely see that there's a benefit to that. But for all schools that do participate in Morris County, we're still looking for at least 3 more schools. So if you're a middle school or a high school and are interested, please feel free to reach out to me. And you do receive a at the moment, it's $3,300 yearly stipend if you do meet the grant requirements. So again, if you want more information, Kelsey and myself are more than happy to meet with your school and discuss what that looks like. As Heather said, it could be any professional in the school. We have, of course, been seeing more counselors are taking on that role who have been a part of that project, but it doesn't mean that a school nurse or a coach, like Heather was saying, could not be a part of that. And then I just want to share just one of the successes, right? One of our student assistant counselors expressed her, success. She's been a part of the project for the past 2 years. And so I do want to just share this quote with you that, she's found the benefit in using SBIRT. She does always express that she has been able to connect with her students that she hasn't been able to before, or meet with students that she hasn't been able to meet with before, because this is something that she could, this resource has been brought to her school. So I will leave you with that. we do have a little time for some questions. So feel free if you guys want to stick it in the chat. And then again, if you want to also, if you want to say it out loud, feel free to also, raise your hand or however you want to do it. I believe we could figure it out. So thank you all.
There is a question in the chat about mental health screening in schools grant program. Is it still happening? It's a depression screening mandate for students in grades 7 through 12. So as an advocacy person, I can tell you that the law still exists. Whether it's actually happening there's always a disconnect. So it's for several reasons. I'm sure that some schools are implementing it, yes. But what we run into a lot when it comes to school-based issues is who's going to do the screening and who's going to pay for it. So that's part of why this SBIRT initiative works well, because there's a stipend, so it is being paid for, which takes care of one question. It is something that will eventually be rolled out. Somebody will make sure that they are enforcing it. If it's something that you want enforced, this is where the advocacy part of me kicks in. Please contact your particular elected officials. So in whatever district you work in, say, I want to make sure this is in my schools that my kids go to, that I work in, however that is. But what they did in the states where it became a law is they actually came back and got Medicaid to cover it. So if you have Medicaid students, or if you have a certain population of Medicaid students, a lot of the schools in Massachusetts, especially, that's where most of the data is, they got Medicaid to cover it. And I believe that in one of the reference slides, the stuff from Kingsway County in Washington, they also got Medicaid to cover the expense. So once the expense is taken care of, then they tend to make sure that it's actually put into place. But you heads up to the counselors and the nurses on this call, because that's probably going to automatically fall to you. So that's part of the reason why I mentioned all of the screenings in it, because it looks like if you're not already doing the PHQ-9, that's probably what they're going to implement.
Do we have any other questions? Yes, there were. Oh, well, yeah, you answered that. Sorry, but the slides and the recording will be sent out. Okay. So no more questions. We don't have any more questions. Well, so then I guess we'll bring it to a close, and we appreciate you all coming. Heather, thank you so much again. We are always appreciative of your presentation and your research skills. So we definitely will follow up. We appreciate you all taking your time out of your day to kind of hop on for an hour of your time to learn more about the benefits of youth mental health screening, and we hope that you're interested in kind of learning more and how you could get involved with screening at your school, or even if not, if you want to have a discussion, if you're in another organization, that is also something else I think that we could definitely open up dialogue about. So thank you again, and have a great day, everyone. Thank you.